Going to be like really short on this one, hopefully, And this time I'm talking about bowel imaging, multi-modality imaging of bowel wall thickening, small bowel wall thickening. And this is mainly directed to residents and fellows, like residents and junior radiologists have nothing to disclose. And I want to emphasize here like the points I'm going to review, like review the pathology, etiology and pathogenesis of a small bowel wall thickening, and cross-sectional imaging findings in case of small bowel wall thickening. And the last thing, and it's really important for you guys if you do these cases, like the relevance of clinical history and all the images in reaching the final diagnosis. This is really, really important if you are reading these cases and if you do any body imaging. And small bowel imaging is a very common but non-specific finding as well. And normally, small bowel wall thickness should not exceed 3 millimeters. If it reaches 3 millimeters and above, this is abnormal. And there are many etiologies for small bowel wall thickening. Sometimes it can be normal variant, but also it can be related to infection, inflammation, or neoplastic process. And all these are causes for small bowel wall thickening. And as you know, small bowel normally enhances, like any normal viable tissue in our body is going to enhance with IV contrast. So if a tissue does not enhance, this means this bowel is ischemic already. So please, because I see many of my residents and our residents in our institution, many times they call the proximal small bowel, especially jejunal lobes, because they are very, they are not well distended and like by default they are somewhat thickened compared to the ileal lobes. Many times they call it like proximal small bowel enteritis, which is not. Like normal bowel should enhance. So please be careful about that. And mucosa is the layer that really is going to enhance compared to the submucosa, because submucosa normally does not enhance. And submucosa will be only evident if it's infiltrated with edema or soft tissue or sometimes like fat. This is the only time we're going to see the submucosal layer, as we will see. And imaging is definitely important. And this table there is an important one if you guys read small bowel diseases. So be careful about the etiology for small bowel thickening, including neoplastic disorders like adenocarcinoma, lymphoma, or GIST, or metastasis, or inflammatory, especially inflammatory bowel disease, or infectious causes like infectious enteritis, and other etiologies, as we will see. And when you look at these cases, try to focus on certain points when you evaluate the bowel wall thickening. Some of the points that I put in white, these ones are related to the bowel itself, which is like how long is the segment that is affected, and which pattern is affected. Is it the mucosa or the submucosa or the entire bowel wall thickness? All these points are important, in addition to the extra bowel or the findings that outside the bowel itself, including lymphadenopathy or mesenteric changes. All these findings can help to narrow and reach a final differential diagnosis. And another table here that is important, because depending on the length of the affected segment, like if the short segment is affected like 5 centimeters or less, this is going to be most likely malignant. But if the affection is 5 to 40 centimeters, it is more likely to be benign. And if it is more than 40 centimeters, it is usually benign. So the longer the segment of bowel being affected, the most likely is going to be a benign etiology. But the shorter the segment that's affected, then the malignant etiology. But the rule is no rule, as you know. The rule that, because sometimes, it looks like this, but the pathology will come like as something different. And you have the etiologies here, like short segment is going to be like an adenocarcinoma, but 5 to 40 centimeters most likely, like Crohn's disease or ischemia or radiation, but still lymphoma can be there among that second group. And we have some images here for a case of adenocarcinoma of the bowel. Here, hopefully you can see this image there. Here is another case of inflammatory bowel disease. And the last case, which is greater than or bigger than 40 centimeters, like in case of infectious enteritis or hypoproteinemia or portal hypertension. And please, hopefully you guys are familiar with this. In patients with portal hypertension, you see wall thickening in the colon, in the stomach, in the small bowel. And as you know, we call it portal denopathy, portal enteropathy, portal gastropathy, portal colopathy. So this is, it's important so that you don't overcall, especially with patients with cirrhosis and portal hypertension. Be careful about that. Yes, it can be infectious enteritis, but give the possibility of portal something like portalopathy, then add the possibility of enteritis or colitis. But be careful, because this is a very common finding in patients with portal hypertension. And this case was a patient with hypoperfusion, as we will see. So imaging features of bowel wall thickening, and I'm sure if you read CT and MRI, these cases we do a lot of CT and MR enterography for these patients. And with these advances in CT and MR enterography, and also capsule endoscopy. Nowadays, we are way better than before in diagnosing these cases. And as you know, plain radiography is completely non-specific. If you look at that plain X-ray, it's completely normal, and I called it normal. But if you look at the MRI feature for the same patient, classic and typical enteritis, terminal ileitis in a young kid with inflammatory bowel disease, Crohn's disease, you know. But the X-ray was completely normal, and we know that. X-ray is completely limited. And this is something like retrospective. Don't think that I was that smart to call this finding from the plain X-ray, like the lead by finding, which actually we called it retrospectively from the MRI. You see this featureless colon there in a case of ulcerative colitis, but it was not from the X-ray, just, you know. But this case is really important. And hopefully you guys are familiar with that, what we call thumbprinting of the colon or the small bowel. This is one of the features that many of our residents, they miss it. You know, like many times, like one of the things that I fix it for them all the time is thumbprinting. And what does it mean, thumbprinting in the colon or small bowel? It means bowel wall edema, regardless of the etiology. This edema can be related to infection, can be related to inflammation, can be related to radiation therapy. So this thumbprinting, when you see it, as if you put your thumb there over that bowel segment and you imprinted that one, your thumb there. Hopefully you guys can see this thumbprinting all over that transverse colon in a case of colitis here. And this is like diffuse wall thickening of that transverse colon in another case of colitis. This is an MRI. I'm sorry if you guys are not familiar with MRI. This is an MRI, it's not a CT. But this is the only finding and only feature in plain radiography that I want you guys to be familiar with. And here is a case of a small bowel adenocarcinoma. And hopefully you can see this wall thickening there. It's a short segment, as we said, and it's more common in proximal small bowel. And circumferential wall thickening, mass-like, and it can have some lymph nodes and metastasis as well. This case was a case of a small bowel lymphoma. You can see the wall thickening there, and there is some sort of thickening as well in the proximal small bowel segments. And lymphoma, as you know, if we combine the primary and the secondary lymphoma, then those are going to be the most common bowel malignancy, if you combine both primary bowel lymphoma and the secondary bowel lymphoma. There are some predisposing conditions for bowel lymphoma, but opposite to adenocarcinoma, distal small bowel is more common in these cases to be affected. And additional findings for sure are going to be like lymphadenopathy and hepatosplenomegaly, or some lesions also in the liver and the spleen. And I want you to look at this case for like few seconds and what you think. Markedly dilated and thickened the small bowel segment, and there is actually like aneurysmal dilatation there, and there is a fistula with the small bowel. There is a fistula, and when you hear that aneurysmal bowel dilatation there, I'm sure all of you guys will think of lymphoma, right? And I was thinking the same way, but I didn't see any lymphadenopathy with this patient, so I called it as GIST, like gastrointestinal stromal tumor in this case, and I put lymphoma as a second option, you know? Again, like we are not pathologists, but one of my colleagues was, and one of the surgeons as well, they were saying, oh, this is a lymphoma. And I said, fine, you know, I put lymphoma in the differential, but in the absence of lymphadenopathy and splenomegaly, I think this is GIST, and I will tell you why. And actually, it came back. They biopsied the lesion with ultrasound, and you can see this typical staining here for GIST tumors, and it came back as a small bowel GIST tumor. And I will tell you why I called it this way, because, and I want you guys to know that, because small GIST, they enhance homogeneously. But large GIST tumor, they have necrosis, and they can also, hopefully you can see this yellow color there, they can ulcerate and fistulize with the adjacent bowel loops. Similar to lymphoma, exactly similar to lymphoma. And one other thing that you have to note is that GIST tumor can metastasize to liver and peritoneum, but it's extremely rare to metastasize to lymph node, extremely rare. If you see lymph node metastasis, then do not think of GIST tumor, do not. And here is another case of metastatic melanoma. This is a really nice case. We had this case like a few weeks ago. Thickened bowel, and one of my colleagues called it either mass or hematoma in that proximal small bowel segment. And MRI, hopefully you guys can see this lymph node here. In addition to the bowel wall thickening, this lymph node has bright signal on T1 and dark signal on T2, which means like it has some sort of melanin there. And the patient has known history of melanoma, so it is metastatic lesion in the small bowel and also the adjacent lymph nodes. Patient with cervical cancer, diffuse wall thickening there in MRI and CT, and also uptake in PET-CT. There is something called subserosal metastasis. It is well-known entity, and it can happen with different malignancies as well. A case of Crohn's or Crohn's disease, and you can see the diffuse wall thickening of the bowel, especially the terminal ileum is affected. Without affection of the terminal ileum, you cannot call acute active inflammatory bowel disease like Crohn's disease. And this is a very, very nice case. I love this case so much because you can see that the mucosa is very hyper-enhancing, and you can see the submucosa as well. And for you guys, should we do like with positive contrast or neutral contrast? This shows you the positive oral contrast there, and you cannot see the enhancement in the mucosa. But with neutral contrast, you can easily see the enhancement. So hopefully this will give you a clue, like when to give positive oral contrast and when you do not give positive oral contrast. Another case of Crohn's disease with the Coombs sign, very nice Coombs sign, like the congested mesenteric vessel, very similar to the comb, you know, like المشط بالعربي, very similar to that. And here is another case with multiple skip lesions. You can see strictures and active inflammation, multiple dilated bowel segments with skip lesions. All these features are typical for inflammatory bowel disease. And I would recommend for all of you guys to read that paper if you read any inflammatory bowel diseases. It's a radiographics paper published in 2020. And it's giving you the different definitions when you call active disease, when you call different terminologies for inflammatory bowel disease. Small bowel diverticulitis, very nice case with multiple diverticula with inflammation. And this patient had an MRI like 2 years before that. And the diverticula were there, but with no inflammation at that time. Very nice case of endometriosis with the typical feature of dark signal on T2. But we knew beforehand that this patient had endometriosis. So when you see that in a patient with known history of endometriosis, please consider that with a specific and typical features as well. This is something, an emergency finding that you don't have to miss that. Be careful to miss any of these findings. Superior mesenteric artery or vein thrombosis, like in this case, you can see the thrombus in the superior mesenteric vein. You can see the thrombus in the superior mesenteric vein, diffuse wall thickening in the bowel, significant edema in the surrounding mesentery, and hopefully you can appreciate the hypo-enhancement in the small bowel, the affected small bowel, which this was a case of superior mesenteric vein thrombosis with bowel ischemia as well. One more case of radiation enteritis. Patient had history of anal cancer and radiotherapy, and you can see the bowel wall thickening, really nice bowel follow through, and you can see the thickened bowel and also the thickened mucosal folds. This case, and I want to ask you in this case, because if you haven't seen this, please look at this, because you can see this small bowel thickening there, diffuse small bowel thickening, congestion. When I look at this case, it can be anything, to be honest with you. It can be anything. It can be inflammatory bowel disease, it can be anything. But the history part, hopefully when I give you that history, you would be coming up with some diagnosis. 47-year-old female with a history of hypertension. And this is exactly what I have done in the reading room with one of our residents. And I told him, look into the history. And with hypertension like this, and before I give you the diagnosis, 2 months before the study, the patient was completely normal. And after we have done something, like 2 or 3 months after that study, we have done something and the patient become completely normal after that. And which means this patient is on ACE inhibitors. And ACE inhibitors, this means it's an angioedema of the bowel. This is very important. And this is, again, when we can make difference. Because all what you need to do, ask the patient to stop the antihypertensive medication or switch to something else. Not to do biopsy or to do anything. And here is another companion case of ACE inhibitor-related angioedema of the bowel. It can take different features. So please check the history. Like in this case, it can be anything. The diffuse small bowel wall thickening there. But when I give you that history, this patient has multiple myeloma and the patient has bone marrow transplant. What do you think? Graft versus host disease, for sure. So the history in these cases is vital. And I know sometimes, I was trained here in Egypt, and I spent so many years in my career here. I know it's difficult sometimes, but put that effort to get that kind of history. Calling the physician, asking the patient, because this can make difference in the patient management, knowing that history, like diagnosis and management. And this is the case I showed you earlier about hypoperfusion related to diffuse small bowel thickening, because this patient was found, as you see in the history here, unattended loss of consciousness, hypoxemia, sepsis, hypotension. So this can happen. This hypoperfusion can lead to this kind of diffuse bowel wall thickening there. And the patient also has intra-abdominal abscess, like subhepatic abscess, this one. This was an abscess subhepatic that could be responsible for that sepsis. So in summary and conclusion, bowel wall thickening is a common finding, but it's non-specific. And cross-sectional imaging is really important in these cases. You have to know the primary imaging features and the secondary and associated features. And please, in these cases, it's important to know the history and the prior imaging as well. So thank you so much for staying that late, and you have a good night.
Thank you, Dr. Ayman.
Thank you very much, Dr.
I would like to
Ayman.
ask you a question. With all these imaging modalities, what is there still a role for barium meal follow-through?
Yes, and actually the fluoroscopy studies, like the need for fluoroscopy has significantly decreased. But mainly nowadays we do it for swallow studies, for patients like have aspiration. This is like significant, like 50% of our cases on daily practice is for a swallow study to see if the patient is aspirating or not. And other cases, like we used to do like a lot of double contrast barium, like for stomach, for colon. Now it's a question and answer, like if there is a leak or not in patients with bariatric surgery or, gastric bypass. And for colon, like chronic, for colostomy, if there is leak or not, or if there is a stricture or not. So hardly in the past like few years, haven't seen any like those double contrast studies that we used to do before, but still follow through study, yes, it is there, especially in ER setting and patients like, they want to treat conservatively for bowel obstruction, they don't want to, intervene surgically, they put NG tube and they may give, but usually they give water-soluble contrast, not barium. Like barium now, like hardly we use barium, hardly. We usually use like water-soluble contrast, especially in obstruction cases, yeah.
I would like to ask another question.
Yeah.
If both MRI and CT are available intrographies, which one would you prefer?
That's a tough question. But I usually start with CT because everybody is familiar with CT. CT has what we call high spatial resolution, which is like, you can take like up to less than 1 millimeter slices. In MRI, you can 3 or 4 millimeters. So the spatial resolution in CT is better. And everybody, like if you ask most of the radiologists here in the room, most of them are familiar with CT. But in young patients, especially Crohn's disease is common in young patients, so I will start with CT, but each follow-up I will do it with MRI. You have a baseline, then MRI after that. Because sometimes it's really sad. I see some patients, they come to ER, and the patient had like in 1 year, something like 10 CTs. Like you are burning the patients, like especially when they come, in US, they come for ER for so like many times, especially for abdominal pain. So CT after CT, like it's so bad. Like when the patient had like 5, 6 CTs in few months, So I would start with CT as a baseline, then later on we can follow up with MRI.
My last question.
Oh, sure.
What about ultrasound of the small bowel?
Ultrasound, I think it's still a work in progress. And I think there are a lot of advances, especially for you guys. I don't know if we use here like contrast enhanced ultrasound or not. Do we?
No.
Not yet?
It's against the law.
Yeah, I think it's mostly like research work for elastography, say ultrasound elastography for assessment of bowel fibrosis and that stuff. Second thing, for contrast enhanced ultrasound, it's still research studies going on. But honestly speaking, it is not suitable for adults, especially like the state where I work on, morbid obesity is a problem there, so good luck with ultrasound in this patient, really good luck. If you put the probe there, you will see nothing, But it's really good for pediatric populations. Yes, I would definitely try to see ultrasound like with, young patients, like pediatrics and young patients, especially if they are, thin, slim, those patients definitely ultrasound will be great for them. But otherwise, I will not.
Any questions?
Thank you, Dr. Ayman, very much for the very interesting cases. I really enjoyed it. And I agree with you very much that the contact with the physician is very important, and knowing the history of the case is very, very important, because lots of time we see just a request for a CT or something without any history, and I don't agree with this.
Oh, yes.
Yeah, you are right, you're totally right. And also taking a history from the patient, like that case that she was taking the ACE, it's very interesting, and it's very important to emphasize on this.
It is, and actually some of the private practices in USA, the patient comes sometimes with like very, very little history. Still they ask the patient, what's your problem, any surgeries before, any medications. They document everything. So even if you guys work like in private practice, or ask your techs to take some notes, or some detailed patient history, trust me, it makes significant difference. And each of these patients is like somebody we know, even if we are not, we don't really know, like somebody like a human being, That's a great point. Thank you.
Thank you.
Yes. I can't hear you well. I'm sorry, I cannot hear you well. Sorry.
When to use
like
positive
IV or oral?
No. Neutral or dye?
Yes. That's another, yes.
Type oral contrast.
Sure. That's another great question. In routine cases, especially like oncology patients or patients coming to, even with Crohn's disease and coming to ER, and I ask our residents, if the patient's coming to ER with abdominal pain and they want to rule out acute findings, then we do with positive contrast. But if the patient, they want to assess disease activity, especially if they have inflammatory bowel disease, we give the neutral contrast. But in general, at least, and it's completely different in different institutions, but at least in my institution, they stopped any oral contrast in ER setting. The patient comes for appendicitis, any itis, no oral contrast. If the patient is coming through ER, no oral contrast. But this is a huge debate, you know. You will not find really some sort of agreement or consensus on when to give and not to give oral contrast. But when it comes to oral, like positive oral or neutral, if you are evaluating disease activity in inflammatory bowel disease, definitely do not give positive contrast. Give the neutral one.
Thank you very much.
Thank you so much. Thank you.
Thank you so much, Dr. Ayman.